Welcome to this webinar on retinopathy of prematurity. I'm Professor Clare Gilbert and I work at the International Centre for Eye Health at the London School of Hygiene and Tropical Medicine in London. And I'm an ophthalmologist who's been interested in ROP for the last 20 years. I'm giving the first of 3 presentations, and this is to really set the scene to talk about the epidemiology of retinopathy of prematurity. So what I will talk about is ROP as a cause of blindness. I'll talk about the clinical features, the classification, and the natural history. And then I will define what I mean by epidemiology and talk about the population who are most at risk of developing the condition, highlighting how that is different in different settings. And lastly, I will highlight the risk factors for retinopathy of prematurity, focusing on those that are modifiable, but Professor Brian Darlow will give the next webinar on how these risk factors can be controlled. So 3 different epidemics of blindness from ROP have been described. The first epidemic was in the United States and in Western Europe in the 1940s and 1950s, and this happened because neonatal intensive care services were established, but people were unaware of the risk of unmonitored 100% supplemental oxygen. And this led to blindness in a very, very large number of people who are now in their 60s and 70s. Stevie Wonder, for example, is blind from retinopathy of prematurity. After oxygen was better controlled, everyone thought that ROP was a thing of the past and that no one needed to worry about it. However, in the 1980s, in high-income countries, as improved neonatal care led to increasing survival of extremely low birth weight babies, that's less than 1,000 grams, these very small babies started to also develop the severe blinding stages of disease. And in Western countries, it was around this time the ROP screening programs started. And the third epidemic is occurring now in the 1990s and in the year 2000 in middle-income countries. And this is happening because these countries too are now developing neonatal intensive care services, and there can be enormous variation in the quality of care these preterm babies receive. So, if you like, the third epidemic is a mixture of first epidemic risk factors with poorly administered oxygen and second epidemic risk factors where increasing prematurity was the driver. So the third epidemic is a mix of those things. Recently, a very large number of studies have been analysed to calculate the number of preterm babies who are going blind for the year 2010. And for each of these pie charts, the total pie chart represents the number of preterm babies who are surviving every year. The dark blue wedge is the number who are developing blindness from ROP, and that's estimated to be around 20,000 each year. And the paler blue is babies who are surviving with visual impairment. And so globally, over 30,000 preterm babies are going blind or visually impaired from ROP. So why does this happen? When babies are born at term, the retina, which is the light-sensitive tissue which lines the inside of the eye, has reached the edge of the eye at the front, and the blood vessels have also reached the front of the eye, and the retina is completely vascularized. You'll see the red arrow there shows the ora serrata, and this is the edge of the retina, and as you can see in this slide, the blood vessels have reached the edge of the retina. This means that babies born at term cannot develop ROP because you have to have an incomplete vascularized retina for ROP to develop. So I hope this shows it more clearly in this slide. Babies who are born preterm, the retina is not fully developed and the blood vessels have not grown out to the edge of the retina. And this means that there is a ring of retina which does not have blood vessels. And these babies are at risk of ROP. So ROP develops at the boundary between the avascular retina and the vascular retina, and you can think of it really as a wound healing response. So the eye responds to the insults and tries to heal itself by growing new blood vessels. But these blood vessels are growing in the wrong place and they are abnormal. So in ROP, something happens to initially stop the blood vessels from growing. And one of the most important factors that does that is oxygen. This means that the peripheral retina becomes even more hypoxic and starts to produce growth factors, which is what stimulate the ROP to develop. So in this slide, it's trying to show you the excess growth factors being produced and the blood vessels starting to grow abnormally. So if I were to look inside the eye of a very preterm baby, well, a 16-week fetus, I should say, you can see the optic nerve, which is the small white circle at the center of the diagram on the top left of the slide. And you would just be able to see a little bit of retina developing around the optic nerve with a few tiny little blood vessels. Over the next few weeks, the retina starts to grow out from the optic nerve and the blood vessels grow along with the retina. By the time a baby's reached 36 weeks of gestational age, about half the retina is completely formed and the blood vessels have reached the edge of the retina, that's the bottom left-hand side, and on the bottom right, that's a term baby at 40 weeks, the retina is fully formed and the blood vessels have reached the edge of the retina. So you can see that the more preterm the baby, the less developed the blood vessels are and the more likely they are to develop ROP. So ROP is classified according to the site, the severity, the signs of blood retinal barrier breakdown and scarring. So the site is described according to zones, with zone 1 being the circle of retina at the back of the eye that surrounds the optic disc. Zone 2 is that ring-shaped area of retina that surrounds zone 1, and zone 3 is the peripheral area of retina. And if ROP develops in zone 1, it's usually much more severe than if it develops in zone 2, and ROP in zone 3 is least likely to go on to cause blindness. The stage is this, or the severity is 5 different stages. Stage 1 is when you can see where the advancing retinal blood vessels have reached. Stage 2, that becomes an elevated ridge. In stage 3, which is now becoming serious disease, blood vessels are growing into the ridge. And then if the disease progresses beyond this to stage 4, that can lead to retinal detachment or total retinal detachment. So stage 4 and stage 5 have got a very, very high risk of permanent visual loss. So this is stage 1. You can see the retina at the top has got blood vessels in it and the retina at the bottom does not. And there's quite a clear line between these two different areas. So that is stage 1 ROP. This is another illustration. The arrow at the bottom shows the line between the vascular retina and the avascular retina. In stage 2, the ridge becomes elevated. This is difficult to see in a flat image, but that is now become into a ridge. And that's another photograph to show you stage 2. In stage 3, blood vessels start to grow into the ridge, and you can just see that the ridge at the bottom there has got a reddish appearance, and this is abnormal proliferating blood vessels. And this is more advanced stage 3, and you can see that the blood vessels are really, it's a big roll of blood vessels there. So those are really quite advanced, abnormal proliferation of blood vessels. If you see this, this is a sign of severe, more severe disease. And this is another example. And this is the kind of image you would see when you use an imaging system called a RETCam, which gives you a much wider field of view. And here you can see this kind of sausage shape of stage 3 ROP between the vascular and the avascular retina. This is stage 4, and the retina at the top of the slide is out of focus, and that's because it is separated from the back of the eye and is detached. So in stage 4 there is a subtotal retinal detachment, and this is highly likely to develop over the next few days to a total retinal detachment. And in this eye here, the retina is totally detached from the back of the eye. There are other signs. One is called plus disease, which is when the retinal blood vessels are abnormally dilated or tortuous, and this is a sign of active disease, and it's a sign that ophthalmologists look for when they're examining or screening babies for ROP. And there is another form of ROP which was recently described called aggressive posterior ROP, and this form of ROP can lead to blindness within 24 to 48 hours. And it's characterized by very marked plus disease, very dilated, tortuous blood vessels, and instead of there being an elevated ridge of proliferating blood vessels, they tend to be flat. So this is very severe disease. And this is dragging of the blood vessels, which can occur when there's scarring in the peripheral retina. So that's the classification of the of ROP. If we now move on to think about the natural history, babies are not born with ROP. It usually starts to develop within 2 to 4 weeks of birth, and in many it regresses completely without any treatment, and the blood vessels carry on growing normally out to the edge of the retina. So when you see stage 1, a very high proportion of babies with stage 1, when you go back and examine them again a week or so later, it will have resolved, but stage 2 disease may have developed. Again, some babies with stage 2, the disease gets better on its own, but in others it progresses to stage 3. Once a baby has developed stage 3, then there is a greater likelihood, around 50% risk, that they will this will develop to stage 4 or to stage 5 disease. And this natural history is important to understand because it influences the timing of screening. And Professor Quinn will talk to you more about this in the last and third webinar. So, epidemiology is the study of how common a disease is, who is most affected, what is the cause of the disease, and what can be done about it. And exactly those same questions apply to ROP. So, how common is ROP? This is not a very straightforward question to answer because it varies depending on the birth weight and gestational age of the babies and the level of care they have received. So in high-income countries where there is generally very good levels of care, it's babies with birth weights less than 1,000 grams who are the most at risk of developing severe disease. Slightly bigger babies may also develop ROP, but it usually gets better without needing any treatment. However, if there is poor neonatal care, then babies less than 1,000 grams are likely to have a much higher mortality rate, and it's the larger babies who are more at risk of the severe disease. Again, this is important for screening because which babies are examined in, say, the Netherlands or in the USA may not be adequate. You may be examining the wrong babies in low or middle income settings, where you'd also need to examine bigger, more mature babies. And again, Dr. Quinn will explain this in more detail. This is a study that I undertook with colleagues, and this is a plot of the birth weight and gestational age of babies who were treated for ROP in Canada, the UK and USA. And you'll see that most of them are extremely preterm and low birth weight. And those two lines show what the UK screening criteria are. And you'll see all but one fall within those criteria, and that one outlying baby had Down syndrome. However, these are babies who were treated in those countries listed on the right, mainly in Latin America. And what you'll see is bigger, more mature babies are also needing treatment or developing disease needing treatment in these countries. And this is very important for deciding which screening criteria to use. Why does this variation happen? It's because of variation in levels of care. So all these photographs were taken in neonatal units in India. The photographs at the top, I think everyone would agree that certainly in terms of infrastructure and overcrowding and how oxygen is being delivered, this is inadequate care, whereas in a private clinic in the same city, very high quality care was being provided. So survival rates and risk of ROP will be very different in those different settings. So the risk factors for retinopathy of prematurity are lack of antenatal steroids and delivery in facilities with poor newborn practices, particularly immediately after birth, and also the degree of prematurity. So prematurity is really the main driver of ROP. So the more preterm the baby, the greater the risk. And then exposure to postnatal risk factors, so suboptimal neonatal care from immediately after birth greatly increases the risk of ROP. And this is just a quick summary of the major postnatal risk factors, because Professor Darlow will be telling you more about that. And these include inadequate administration and monitoring of supplemental oxygen, sepsis, failure to gain weight, poor pain and temperature control, which can make babies unstable, and poor supportive care. So the next two webinars, Professor Darlow, who is a professor of neonatology in New Zealand, will highlight how to prevent ROP by controlling risk factors, and Professor Graham Quinn, who is an ophthalmologist in Philadelphia in USA, will talk about screening and approaches to treatment. Thank you.